Hello and welcome to Health Professional Radio. I'm your host, Neil Howard. Thank you so much for joining us for another segment. We're going to have a conversation with Dr. Jerome Goldschmidt. He's joining us here from Blue Ridge Cancer Care to discuss his poster presentation from the American Society of Hematology, or ASH 2021 annual meeting. Welcome to Health Professional Radio, Dr. Goldschmidt. Thank you for taking the time.
Well, thanks for having me here this morning.
Well, I mentioned that you are joining us here from Blue Ridge Cancer Care. Give us a little bit of your professional background. Tell us a little bit about who you are.
So basically, Blue Ridge Cancer Care is part of the U.S. Oncology network, and we, do a lot of clinical trials through U.S. Oncology and through other sponsors. We've done a few trials with G1 Therapeutics, which has a product on the market called trilaciclib, which is involved in myeloprotection, which is probably why this poster appeared in ASH. You don't normally see small cell lung cancer trials presented at ASH, not your plenary session or even oral abstract typically there, but nonetheless, we have a lot of small cell lung cancer patients in our region. Since we are in the Appalachian region, heavy smoking area, and this is a pretty significant part of our practice. So we place many patients on these studies and have myself, but also my other investigators have a lot of knowledge about some of the healthcare utilization and the costs of this care. So that was really the genesis for this project. And really led to working with Ontada, which is also a spinoff of McKesson and U.S. Oncology, to really gather the data from our electronic medical record to work with G1 Therapeutics so we could have this nice poster presentation to really show the burden of myelosuppression on these patients.
Give us an overview of this myelosuppression poster that you presented at ASH 2021, if you would.
Well, I guess the first part of it we did earlier in the year at a previous conference, and we just looked at the overall burden. And then in ASH, we honed in on the healthcare resource utilization. So what we did was we took 5 years of data and looked at small cell lung cancer patients in the U.S. Oncology network as entered into our electronic medical record. And these patients were divided, first small cell lung cancer. It turned out to be about 1,400 patients. And then they were divided into grade 3 hematologic adverse events. And these were roughly 1,400 patients, and about 2/3 of them had at least one grade greater than 3 hematologic adverse event. And so that roughly 800 patients, we looked at the healthcare utilization and then calculated a cost for what it meant to go on myelosuppressive chemotherapy for small cell lung cancer, what that did for outpatient costs, and was there a difference between folks who didn't? And what we found was that yes, there was more healthcare utilization. There was also more patient dose reductions in chemotherapy. There were more dose delays, which are hard for patients, and not to mention physicians and the kind of treatment centers. And then when you looked at use of growth factors such as Neulasta, Onpro, et cetera, that was higher in this cohort of patients. So this expense was more. One thing we did not look at was inpatient expense for febrile neutropenia or for transfusion costs. We really only looked at the outpatient space in our structured data. But that number that we came up with, there's about $8,000 difference, more expensive if you had greater than or equal to 3 hematologic adverse events. That number is probably very small relative to what's really out there.
Are there any new options available to address chemotherapy-related myelosuppression in small cell lung cancer?
Well, there's really only one option for myeloprotection, and that's trilaciclib was approved early last year. As far as prevention, you can certainly use your growth factors, which address just one cell line. So granulocyte colony stimulating factors have been around for over 20 years. They've been used in various pegylated forms and now are biosimilars. They address low white blood cell counts. Anemia can be addressed by erythropoietin stimulating agents. For platelets, we really only have the use of platelet transfusions, but nothing really new is out there other than biosimilars, and that's just bringing the cost down slightly, not dramatically. There is some data coming out from a company called Beyond Spring and looking at plinabulin, which has a different mechanism of action than trilaciclib, and that may be forthcoming as a myeloprotectant. So there is a research that is ongoing in looking at myelosuppression, because this is 2022 and it's hard to think that we're talking about chemotherapy treatment for cancer. It's hard to think about wars in Europe as well, but nonetheless, these things happen, and we are not going to wean ourselves off chemotherapy anytime soon in many cancers, and so myelosuppression still needs to be dealt with. It's also, we're in a pandemic, and myelosuppression is, doubly dangerous for these folks. New research, new information is obviously forthcoming, thankfully spurred by some of what we've experienced the last couple of years. And then lastly, cost is important, because cost of care and value-based care is really driving our healthcare utilization these days. And oncology care model practices, there's over 100 in this country that are striving to reduce the costs of care for patients. And this is one means to do that, keep patients out of emergency departments. Expensive drugs to maintain their white blood cells or red blood cells artificially is definitely a step forward.
Speak to considering the oncologists who are attempting to manage SCLC with the best available therapies.
So, I see small cell lung cancer patients every day. So I'm one of these oncologists. Generally, we try to, we want patients dosed appropriately, and we want them dosed on time. We don't like to have patients come in mid-cycle and have severe mucositis or a fever and have a white blood cell count in the grade 4 range. That means oftentimes hospitalization, and those patients consume a lot of nursing time and nurse navigating time, and you're frankly, as a physician, you're worried about these people because they absolutely could die from an infection at the drop of a hat. So this is a cause for a lot of consternation. One of my friends' father was an oncologist in the very early years of oncology in the 70s. And he has PTSD from myelosuppression. So, he said he couldn't sleep at night thinking about all the people he had who were, could die at any moment from a neutropenic fever, et cetera. So no, it's a real concern for oncologists. Small cell lung cancer is just the start. Obviously, this is a niche. And thankfully, small cell lung cancer is on decline in our country and in the world as smoking cessation persists. But I think I would look for other myeloprotectant strategies with other cancers, namely breast cancer, even colon cancer. So this is going to be forthcoming, and medications like trilaciclib, plinabulin, and maybe with or without the growth factors may be forthcoming. So look for that in supportive care. And supportive care still matters. It's important. We're not just putting everyone on immunotherapies these days.
Well, I appreciate you taking the time this morning to speak with us, Doctor. Thank you so much.
Well, thank you. It was a real pleasure, Neil.
You've been listening to Health Professional Radio. I'm your host, Neil Howard, in conversation with Dr. Jerome Goldschmidt. Audio copies of this program are available at hpr.fm and healthprofessionalradio.com.au. You can also subscribe to the podcast on iTunes, listen in, download at SoundCloud, and be sure and subscribe to our YouTube channel at youtube.com, Health Professional Radio.